Good morning, good afternoon, and good evening, everyone. Welcome to another week of Global Cafe. My name is Melady Mystery, Senior Policy and Project Coordinator here at the IFA. And today I'm very excited to be introducing you all to Dr. Dawn Melady on the topic of care of older adults in emergency departments. Dr. Dawn Melady is a staff emergency physician at Mount Sinai Hospital and a professor of faculty at the Faculty of Medicine at the University of Toronto. He has been involved with improving the care of older adults in emergency departments for 2 decades and has certificates of added competence in both emergency medicine and care of the elderly. He is the director of a fellowship in geriatric emergency medicine based at the Schwartz-Reisman Emergency Medicine Institute, or SREMI, the founding chair of CAEP's Geriatric Emergency Medicine Committee, and the chair of the Clinical Practice Committee at the International Federation of Emergency Medicine. He sits on the board of the Geriatric Emergency Department Accreditation Program of the American College of Emergency Physicians. He recently co-authored a book, Creating a Geriatric Emergency Department, a Practical Guide, published by Cambridge University Press. So thank you for joining us today, Dr. Melady.
Delighted to be here. Thank you for the welcome, and it's nice to see all these faces and names online, including a few familiar ones. Hello, Joel, whom I've worked with for many years. So very happy to be here. Thanks for the invitation.
Absolutely. Thank you so much. So I think I just wanted to start off our chat with kind of asking you, what is the source of inspiration or the path that you took to essentially get into the work of the field of caring for older adults within emergency departments?
Thanks, Mitali. So there's a bit of a challenge for me because I'm accustomed to speaking to audiences of emergency department folks, my peeps, and it's a special culture. And I'm aware that I'm speaking now to a general audience who may not think about emergency departments much in their daily life until they need one. So emergency medicine in North America and in most of the world, where I see people calling in from, is now a recognized specialty. So emergency physicians train for 3 to 5 years to work exclusively in emergency departments, and which are site-specific parts of a hospital that are directed at the assessment, identification, stabilization of serious injury and illness across the life spectrum. So one of the mottos about emergency medicine is anywhere, anytime, anybody. So it's a brief and often a brief encounter, or brief in terms of hours usually. So that's what emergency medicine is about. And the people who go into emergency medicine, and when I say emergency medicine, emergency department care, so nurses and physicians are the main people in emergency departments, tend to be people who like things fast and snappy and complicated problems that they can solve quickly. They have short attention spans, like to get things done quickly and move on to the next thing. And that's me too, and that's what drew me to emergency medicine 37 years ago when I was leaving medical school. I also have long had a strong interest in older people. I grew up in a large, rural, Irish Catholic family, surrounded by a lot of older people, and older people just seemed like a normal part of life from the time I was a child. And I wish that was an attitude that everybody in the world had, that being older is just as normal a part of the human condition as everywhere else. So I actually, when finishing medical school, I was struck with the sort of decision of going into emergency medicine, or my other second choice was actually going to be geriatric psychiatry, which is certainly a very odd combination. So I chose the one path, but retained a lot of interest in the realities of older people and older person medical care. And through the first 15 years of my career, when I was working in a community hospital, I really, of all the things that I was doing, which included major trauma resuscitation, major medical resuscitations, complex children with cardiac arrest, I we did the whole thing for sure. I always found looking after older people to be very interesting. Both it was personally gratifying because I felt that I was really helping somebody. It was intellectually very stimulating in a way that sometimes the other stuff was not. So it really made me think deeply about the problems and put complicated things together. And it involved working closely with colleagues, which was not, emergency physicians can sometimes be the lone wolves of the medical world. Whereas when I was working on the care of an older person, I was often interacting with other of my colleagues. So I really liked that even when I was doing general community-based practice. When I came to Mount Sinai Hospital at Toronto and the University of Toronto, I told my chief, and this was back in 2005, I told my chief that I would really like to focus my academic activities on geriatric care in the emergency department, and certainly eyebrows were raised because 20 years ago that was not really something that people thought about. It certainly was not on the horizon of acute care medicine. And so for the last 20 years, both within our emergency department and then quickly working outside the emergency department within the region of Toronto and then nationally and then internationally, I would say a small cohort, a small but powerful and intensely committed cohort of other emergency physicians, nurses, and physiotherapists and social workers have really created this new field of what we call geriatric emergency medicine, or more accurately, geriatric emergency department care. So it's bringing together, developing the field has been to bring together people nationally and internationally to create new standards of care, new approaches to care, a new evidence base by doing research, guidelines for care, support for implementation of new processes of care. I hope that wasn't too much.
No, that was fantastic. Just a quick glimpse into your life, what affected everything, and a little brief description of emergency medicine. Speaking of, I know you kind of briefly touched on what emergency medicine is. I was wondering if you could speak a little bit more to it, and how would you define it in regards to the care of older adults?
Well, I mean, I sort of sketched that a little bit. In one way, it's quite different and a little bit conflictual, and in other ways, it's very analogous. So, emergency department care typically is quick, fast hits. But really, it's a place, the emergency department, every emergency department in the world is a place where complex problems come. I mean, say sometimes they're simple problems. A broken wrist in a 22-year-old who falls off her bicycle. It's a disaster for the 22-year-old, but it's a very simple problem for an emergency department to address. But it is really, emergency departments are a place where very complex problems come, and problems that I guess I could call them situations, but they're problems that intersect across multiple areas. So what doctors think of as surgical problems, so things that need interventions, medical problems, things that need attention with medication or non-surgical approaches, psychiatric problems, and of course then connected with social problems. So we're accustomed to dealing with intersectional challenges in the emergency department. And emergency departments have typically been really great team-based places. So the earlier referenced lone wolf emergency doctor is generally not very successful. That's everybody's observation, that really to work successfully in an emergency department, you need to be a team player. You need to work with your other medical colleagues, both the ones in the emergency department and your consultant base, and work very closely with the nursing staff and ideally social work and physiotherapy as well. So people working in emergency departments are very familiar with complex problems and team-based care. So as it happens, I think any of the clinicians on the line or others would recognize that those are two of the main things when it comes to managing older person care as well. So the challenges are rarely simple and straightforward. They're usually complex and intersectional. They challenges arising in older people, particularly coming to the emergency department, you often cut across surgical, medical, psychiatric, social, mobility, medication. There's probably a few others. So like they typically involve a lot of different compartments. And everybody has always said that geriatrics is the ultimate team sport, right? Anybody working in the care of older person, in the field of older person care, works in a team. There's no such thing as a solo geriatrician. She always is working with a team of other people. So in many ways, the two fields go together quite nicely. I don't know if that gets at the core of your question.
Yeah, absolutely. And I think the two important points we got out of that one was how intersectional the care is of older adults in emergency departments and the fact that it is completely team-based. You know, you definitely need multiple disciplines kind of interacting with each other and helping each other out with the multiple, the complexities that might come with dealing with the care of older adults. So no, that was excellent. There are so many changes that need to be made with our healthcare systems and, having this incorporation of this type of care for older adults. How can we make these changes to our healthcare systems to allow it to function more efficiently and really accommodate for the needs of older adults? As we discussed prior to today's session, you mentioned people, place, and processes being paramount to these changes. Could you speak generally to what's required of each of these?
Sure. So I will shamelessly declare a conflict of interest here because I am going to mention the book that you referenced earlier. And in fact,
Fantastic.
a colleague of mine, John Schumacher, wrote a book for Cambridge University Press called Creating a Geriatric Emergency Department. And we structured it around those things that you mentioned: people, processes, and place. And probably, this structure applies to an approach to older people everywhere, not just in emergency departments, but in transit systems, in tourism, in employment. So I challenge the audience to kind of think about how people, processes, and place apply more broadly. But so the way we in the field of geriatric emergency medicine think of the changes that are needed are ensuring that there is a work staff, the people are in place. So, and that in general, within medicine, within the House of Medicine, and I'm including nursing and all the associated health disciplines, generally, we don't learn a whole lot about older people during our training, our general training. You can't learn everything, but it is a bit surprising in most countries now where up to 25% of the population is over the age of 65. It's a bit surprising that there hasn't been that pivot in healthcare education to really focusing on the core user group of healthcare services, which is older people. So that within the emergency department, that's one of the things that we focus on is just plain education. So on Wednesday of this week, I did a 4-hour course with 30 emergency physicians at one of our neighboring hospitals here in Toronto, and really drilling down on the relevant medical topics that are specific to older people coming to emergency department. And so like things that the general public might not think about, like, so how is traumatic injury different in older people, and how does it require a different approach? Medication management many physicians don't know a lot about medications, which might surprise the general public, particularly as it relates to older, complex, frail adults who may be taking 10, 12, or 15 medications. So part of the approach to changing the system is making sure that you've got a trained, well-educated work staff in place. And then going back to the team sport concept, making sure that in the emergency department, there isn't just a doctor and just a general practice nurse, but that you really have to think about adding some extra staff to the emergency department. I've been so lucky to work at a place, Mount Sinai Hospital, that has been older person friendly for forever, I think, certainly for the 20 years that I've been there. I stepped into a great place. And one of the defining things was that we've long had what we call a geriatric emerge management nurse as part of the core emergency department staff. So that's an advanced practice nurse, a nurse practitioner or other, who really has focused knowledge and expertise in the care of older people, who's there like most of the time and can not take over the care of the older person, but support the medical care of that person to ensure that everything is being covered, not just the medical, but also the functional, the social, the cognitive components. We also have access to a physical therapist and an occupational therapist who are available to assess older people in the emergency department for 10 hours of the day. And that's really helpful around arranging appropriate discharges if the person has a new level of mobility, say because of a fracture or a musculoskeletal injury. What does that person need? But sometimes it's just about having a pneumonia that makes the person weaker, and what kind of physical supports do they need at home. We also have a social worker who's available to see the person. We're incredibly well-resourced in that we can actually access a geriatric consultation and even a geriatric psychiatry consultation in those rare occasions where it's going to make a big difference in the emergency department care. So building a team of people in the emergency department is essential. And I think the audience online can see that that's probably the case across all sectors as well. So that's the people part. The processes then, we think of processes of care, and really that's another place that a lot of changes need to be made, because there are things that are quite specific to older people that we need to have processes for managing. So a couple that come to mind are many older people, up to 10% of older people in emergency department are suffering from a condition called delirium, which is a new change in their mental status. Sometimes that's obvious. Most of the time, it's not obvious, in fact, and it often goes unrecognized. So having a screening process in place for an important complex condition like that would be an added process to many emergency departments. Similarly, a person's level of frailty is going to have, we are now aware that a person's level of frailty has a big impact on their medical condition, how their medical condition is identified, and the consequences and outcomes. So a robust 90-year-old with pneumonia is probably going to do quite well and doesn't need much more attention than a 40-year-old with pneumonia. A very frail 68-year-old, because of complex medical conditions, frail for those reasons, with the same pneumonia is probably going to need a lot more support, is more likely to develop delirium, is more likely to need hospital admission. So identifying that is more likely to have a poor outcome, perhaps a long stay in hospital, maybe needing an advanced level of care afterwards. So knowing early on and identifying what that person's level of frailty is can be a very important care process in the emergency department. I think many of us are aware that elder abuse and neglect or elder mistreatment is a reality in our world across all cultures and all socioeconomic classes. And certainly, as we know, it is not easy to identify. Emergency departments around the world are getting more involved in that issue. And so having some kind of a screening process in place to try to identify possible cases of elder abuse and neglect are important, and then having processes in place where you can take some kind of helpful action that will help address that. So those are, as you mentioned, I work on an accreditation program. Our accreditation program lists 30 different care processes that you can put in place. I don't think anybody wants me to go through all 30, but I can if you want.
That's fantastic. That's incredible that there are already 30 processes that are put in place because that's um, really essential to kind of have that system there, and we can actually have, the works go through and ensure that people are getting the correct treatment and, right way of handling situations. That's fantastic.
Yeah, I need to make clear that, like,
Yeah.
I make it sound so easy, all right?
Yeah, it's
It
very complex.
making changes, even introducing one of those care processes into a complex ecosystem like an emergency department is a big task. And so those emergency departments around the world who are committing to becoming more older person friendly, becoming geriatric emergency departments, are really taking on a heavy lift. It involves staff training um, so many changes to your IT system, for example, things that you might never otherwise think about.
Yeah, absolutely. So you touched on people and processes. I was wondering if you could touch just a little bit on the place as well.
Gee, Mitali, you're actually listening to what I'm saying. So place comes third in this list, people, processes, and place, and that's intentional because it's probably, we think of it as the least important. Because if you don't have an educated, committed workforce who is working within a care system, the the processes that allows them to do good work, then it doesn't really matter how nice your physical environment is. And so this is something I always like to highlight for general audiences and medical ones, that people always, when they hear old geriatric emergency department, they sort of start thinking, oh, it's a place where things are nicer and the lights are lower and the beds are softer and those things are great if you can swing that, if you can have a special quiet place, but really it's the other things that are the most important. So simple components of the place, of the physical environment, that need to be in place are the things that we often don't think of, like an intervention as simple as having two chairs in the room where the older person is being cared for. Why? Well, every older person should be connected with a family or other caregiver. Sometimes they're not. But if an 82-year-old woman is there as the patient and she has an 86-year-old husband, he needs to be, he's part of the care dyad. And so but if we don't have a chair for him to sit in, how can he participate for the, 6, 8, 10 hours of the emergency department's stay? So simple things, a simple thing like that. Making sure that there's food available, because emergency department stays can be long and they're often a food desert. But if you've got a person who stumbled going to the bathroom first thing in the morning and broke her wrist, she could well be in the emergency department until 9 o'clock at night. She didn't get breakfast. She hasn't had supper or anything to drink since last night, unless we're sure that she and her 86-year-old husband who have come with her have something to eat. That's not good care, and you're not going to have a good outcome. Food, someplace to sit, food, drink, a clock in every room. Our emergency departments can be incredibly disorienting places. They're the same at 2 in the afternoon as they are at 2 at night. It's often impossible to know where you are. So just having something as simple as a clock. This is an evidence-based intervention that is shown to decrease the development of delirium within the emergency department. Making sure that you've turned off the monitors so they're not beeping and squeaking the way monitors do, decreasing the number of tethers that we put on people like cardiac monitors. Of course, if you need one, then you need to have that in place as well. Ideally, having rooms with closing doors for the older person so things are a little bit quieter, getting people out of halls. Those are some of the like really simple, relatively easy to implement changes in the place that we could put in place.
Yeah, thank you so much for touching on that. Really important things, both for older adults themselves, but also for the staff, the people that are also working there, because, everyone kind of has to have peace of mind, sound of mind, especially in a very chaotic environment. Got to make sure everything is up to speed with everything, including the clock, which I never even thought of as a thing.
I'd just like to throw in
Yeah.
one other people, which is a something that I think the audience might be interested in. A lot of emergency departments, and our place started about 7 years ago, have added a volunteer program to the emergency department, not just a general volunteer, but one specifically focused on attention to older people. It's modeled on the famous HELP Hospitalized Elder Life program developed by Sharon Inouye, which has had a huge impact in acute care of elders in hospital floors. So we sort of brought that to the emergency department. We have a group of, I would say, very high skill volunteers whom we give additional training to. They're high skill because they usually have had experience working in complex work environments and experience of providing care, not necessarily to older people, but providing care of some kind. Then we give them some additional training in challenges for older people, and they're available in our department, sadly only 8 hours of the day, but they often are an intermediate. They support older people by sometimes doing nothing more than sitting down and talking to the person. But like, what's more important than having somebody sit down and talk to you when you're feeling sick and worried and isolated in an emergency department? So an intervention, and no hospital staff has time to do that, and it's not part of their job description. So doing something as like adding a volunteer program to address those other softer but very important issues can be great.
Yeah, that's a really important point, because I know that a lot of people feel, it's a very scary time to be in an emergency department. And so having someone just to chat with, just to, they just want to hear your mind, what's going through your mind right now, and having a calming kind of person to speak with, especially, the staff is kind of going back and forth in the chaos of understanding what is happening in terms of helping with your care. So I think that's incredible. And I hope that more and more, hospitals and clinics kind of start implementing kind of a system like that. I think that's fantastic. So I just want to ask you one more question before we open up the floor to our audience members. So if anyone in the audience has any burning questions, now is the time to kind of post them in the chat if possible. So my final question right now is, as you mentioned, you sit on the board of the Geriatric Emergency Department accreditation program. So what does it exactly mean for an emergency department to be accredited for the care of older persons? And, where might this accreditation process extend to outside of the US, for example?
So this is a program administered by the American College of Emergency Physicians. It's a huge triumph for the field of geriatric emergency medicine. And that's such an important organization, because it is the largest emergency medicine organization in the world, has taken it seriously, and has recognized that this is an important activity. So the idea is, and I should just say that it's generously supported by our friends at the John A. Hartford Foundation, also, and others. So we couldn't do this work without them. It is. We developed it, and I sit on the board and was part of setting it up over the last 7 years, I think. It is it's a method to recognize emergency departments that have made significant changes and built in to their care changes that improve the care of older people. And not surprisingly, it's kind of touches on those three things: people, processes, and place. So the basic criteria are that you need to have a physician champion who is identified with improving care of older people, a nurse champion who's identified with improving care of older people. You need to have additional education in place for all of the staff. You need to have a certain number of care processes in place. You need to have some basic changes in your physical environment. You need to have some quality improvement measures in place that demonstrate that you're actually, the track that you're actually doing those things, because it's fine to introduce a dementia screening program, but then if nobody's doing it, it doesn't really matter. So the quality improvement part is there. And then you need to have executive level support for this. It's at 3 different levels. Level 3 is the lowest, and that would be just one new care process that you've implemented. Level 2 is 7 of those care processes. And a level 1 is really, the gold standard, and that would be implementing 20 new care processes. And that's really a major change. We're delighted that in these last 5 years in the United States, where the program is based, there are 500 emergency departments that are now accredited as geriatric emergency departments, and there are only 5,000 emergency departments in the States. So 10% of all emergency departments now have committed to making at least some changes, and there's about 10 or 15 of them are level 1 geriatric EDs. The program is also available around the world. There are a number in Canada, maybe 8 or so. There's a level 1 in Switzerland, many in Spain and Portugal, in Thailand, in Brazil. So I think people are becoming more familiar with it, and using it as a structure for making change and having that change recognized. It also, on a practical basis, it often gets you a reputational lift. So if your hospital is wanting to enhance their reputation in the community as a place that is a great place to take your grandmother or grandfather to, it can often be a philanthropic driver as well, that people like to donate to places that provide good care for older people. So there are multiple reasons that people do choose to become an accredited geriatric ED.
Even in the comments here, we have Jane Carmody, who says that 519 emergency departments are accredited at this point and 20 more in the process for final review. So that's fantastic to hear that, it's continuously moving along. And so I'm going to move. Oh, yeah, yes, go ahead. Yeah.
It's sort of as a bit of inspiration for all of us people working in the field of care of older people or attention to older people, where we sometimes feel like nobody's listening to us, and nobody taking this issue seriously. 15 years ago, 10 years ago, if you had told anybody in the world of emergency medicine that the 10% of the emergency departments in the United States would be committed to geriatric care, that would have been amazing. So it really, we are making progress. People are paying attention. decision makers are noticing that a quarter of our population is over the age of 65, and in some places up to 50% of people going to emergency departments are over 65. So shouldn't we be doing something different? Yes, we should.
Absolutely. And I'm just going to shift a little bit from the accreditation process and kind of go into more of the yeah, some of the social factors involved. We have a question here from Shmuel, and he's asking, according to you, you do see quite a lot of people coming from different walks of life. What is considered in improving the care of older adults experiencing, coming from maybe a lower middle income socioeconomic area? And then we also have a kind of related question from Chris Corbis, who asks about the care in maybe more rural areas where resources might be lower.
The second of those is both easier and harder.
Mm,
It so it's interesting. We do think a lot about care of older people in rural and remote areas, and we haven't got to talking about the geriatric ED collaborative that I'm involved with, but a lot of our thinking there does connect to we aren't just interested in looking after upper middle class people in downtown Toronto. We are interested in how older people are cared for across the spectrum, including in rural and remote areas. Um, and I did a webinar on this about a year ago, which we can, if you go to the GEDC website, you'll find it. Care of older people in rural settings can be both easier and harder. It's harder because yes, there may be fewer resources. It's going to be very hard to implement a physiotherapy program in your emergency department when you don't even have a physiotherapy program in your 15-bed hospital. But there are coming out of the webinar, it was really interesting that a lot of people said, a lot of the problems that you people in Toronto have, or big cities, we just don't have. It's much easier to make community connections. We know what is available in our community, and there's often like more support available than there would be in Toronto, in a large city. The network of care is much stronger. People are clearer about what their goals of care are, and that they, when it comes to a transfer out to the big trauma center far away, people are more willing to say, I think I'd sooner stay here. I don't know what, like the outcome might not be quite as good, but I'm happier to stay here. So, so there are advantages to older person care in smaller settings as well. Yeah, and the other question about socioeconomic, could you just refresh that?
Yeah, absolutely. Kind of, people might be coming in with lower middle income situations. And so certain, depending on where you're coming from, maybe care is accommodated for, it's funded, so you don't need to really worry about things. But there are other considerations to make for perhaps they're, getting prescribed this other medication that they had to pay out of pocket, or other treatment plans that, they might maybe have, the bus ticket, money to take the bus fare to actually go to the clinic to get the care or treatment. So what are some of the considerations, just a general,
Just
that might bring to mind?
one very specific one about
Yeah.
transfer. So, for example, one of the care processes for a geriatric emergency department is ensuring that transit home is thought about, ideally covered, and then some kind of follow-up to ensure that the person, if we've referred the person to a geriatric psychiatry clinic for follow-up, to make sure that they do have a way of getting there, and or that they're linked to some kind of a community provider that would do that. So like those are the kind of practical things that emergency departments tend to be pretty practical. So, but we sometimes don't think about those practical realities for older people. And thinking about care of older people who are less financially advantaged is like super important, and that's the whole equity, diversity, and inclusion component that we all should be thinking about, and we do think about that with care of older people in the emergency department. How are we ensuring that the person with very limited resources, financial or social resources, like many people don't have family members who are able to support them, rich or poor,
Mhm.
and certainly many people cannot afford the things that people with lots more money can afford. So keeping that in mind and making sure that we try to even out those inequities as much as possible. I'm not going to imply to this audience that that kind of thing is easy, but
Mhm.
it's impossible if you don't think about it.
Absolutely. And I think it's a matter of, having those discussions with other staff members who might have had a little bit more experience dealing with that together. So we have a question here, a hand raised from David Stewart, if you wanted to unmute and ask your question.
I'm an 83-year-old physician who used to work at St. Michael's Emergency in Sunnybrook. Many years ago, I was hired at the Mayo Clinic, and I came back to Toronto after a while. And I've been in an emergency twice over cardiac problems. And what I have noticed is the communication is terrible. They don't tell you what they're doing. They don't tell you how long it's going to be, even if it's reference, 4 hours, 3 hours, whatever. They don't, the communication is absolutely disgusting. And I can compare that to my experience at Mayo, Rochester, Minnesota, where the communication is the first thing they start talking to you about. And everything else, I certainly believe we need to do about geriatrics. I mean, there's nothing about that. But it's communication. Otherwise, the service was okay. And if I wasn't a physician and could read the cardiograms and everything else, all the notes, I would be really frustrated. So communication would be one of the most important things to talk about. They just don't tell you things.
Mhm.
So that's why, thanks for that comment, Dr. Stewart. That's why I put people first on the three P's of people, place, people, processes, and place. Because unless we have a staff, a workforce that is aware of people's needs, older people, younger people, but specifically older people. So and I think it's relevant to you, like, a 22-year-old with a broken wrist is not going to be spending 4 or 8 or 12 hours in the emergency department. And you can tell her, before you have time to tell her how long it's going to be, she's already gone home. So just being aware that the older person is going to be different, and having strategies in place to and making sure that our staff know that you need to do things differently and communicate differently with older people.
Yeah, absolutely. And I think that also what you mentioned before, it comes from the training part of, having ensuring that the staff members can understand that communication is such a, important part of this process. And so maybe that kind of starts from medical school training, and then it kind of works down towards, you know, specific hospitals and clinics and stuff like that. Yeah, absolutely. Go ahead.
I'm just taking have had a second to look at some of the chat. I noticed
Yeah.
Kelly here is here from the geriatric emergency management teams in Ontario. For those, I mean, and she's fortunately put in a link. I would urge everybody to go there. For those, Ontario, the province of Ontario has had a program for the last nearly 20 years called Geriatric Emergency Management Nurses. They are present in most larger emergency departments. They have been absolutely transformative to the care of older people in emergency departments. The program is a model to the world, and I wish more people were doing it. So that it's what I referenced earlier, the GEM program, GEM nurses, who are advanced practice nurses working in the emergency department to do all the other important things that the physician is not doing. So physicians are only going to do medical stuff. That's what we're good at. That's what we're trained to do. That's the job description. That's what we do. But as we've already established, there's a lot more stuff that needs to be done with complex, frail, older people. And unless you have somebody whose job it is to do that, it's not going to get done. And so to go back to Dr. Stewart, I'm sure that if you had been in an emergency department that had a GEM nurse in it, the communication would have been much better because he or she would have been there sort of quarterbacking, directing a lot of the care and making sure that all the other things that need to be done are done.
Absolutely. And thank you for making note of that as well. That's in the chat if anyone wants to visit that link. We have another question here from a Dr. White who asks if you could briefly explain emergency department triage and maybe specifically to older adults.
Thank you very much. So that's one of the another one of the care processes that I didn't get to. So triage, for those people not in the ED world, emergency medicine world, triage is the first process. It means sorting. It's used in every emergency department in the world using various approaches, but it's a way of identifying the people who need most timely access to the people who need least timely access. So typically a resuscitation to a non-urgent problem. It is now a one-size-fits-all, and does, in most places, although this is changing, does not address the particularities of older person care. So, for example, within trauma, typically anybody with a blood pressure below 90, a systolic of 90, is a triage level 1, the most critically critical. But in fact, by the time you reach your 70s or 80s, if your blood pressure drops below 105, you are probably equally critical, but our systems have never addressed that. So an older person going to an emergency department with a blood pressure of 100 would not currently be flagged as critically ill because their blood pressure hasn't yet dropped below 90. But if an older person's pressure drops below 90, that's really bad. So our triage systems, both at the front desk and system-wide, so another triage is used by pre-hospital care or ambulance folks to decide whether a person goes to a trauma hospital or to a general hospital. And they generally use the same criteria for both young people and older people. But we know, so for example, mechanism of injury. So if you're shot with a gun, for sure you're going to get taken to a trauma unit. But if you're 40 years old and trip over your dog and fall, you won't get taken to a trauma unit. However, if you're 80 years old and have a fall from standing height, as we call it, so if you trip, the 80-year-old trips over her dog, that person probably, based on the mechanism of injury, should go to a trauma unit because we know that the single largest cause of polytrauma, multiple trauma, is older people falling from standing height. So it's I don't know, that's probably a little too specialized for non-clinicians, but it's just another example of where we're slowly catching up with the reality that our one-size-fits-all does not fit older people.
Yeah, no, I think it's good that you kind of gave a specific example and explained kind of how that process works. It gives us a better understanding of, what exactly is happening. They're not just picking and choosing. There are complex processes that you guys are going through in order to manage the care of an older adult.
Just another thing that we're trying to get built into triage systems is identifying frailty and the level of frailty, because we know that a person with advanced frailty, and people maybe familiar with the clinical frailty scale, so 1 to 9. Anybody with an advanced frailty scale score of 7 or 8 is going, even with a simple problem, is probably going to deteriorate quite quickly. So identifying the person's level of frailty early on at triage, in fact, is important. So, but we're a long way from doing that yet, but we're working on it.
Okay, all right, that's fantastic. And I know you mentioned, oh, we have a question here. Let me just quickly read through that here. Oh, yeah, it's just a comment here from Jane T. Steele, speaking on person-centered care. I do know that Sunnybrook Hospital, based in Toronto, through the GEM department, provides kits to older persons coming through the emergency department, providing eye patches so the bright lights don't bother them, earplugs so they block out the noise, and other activities that keep them busy. So when a client of theirs goes to emergency from retirement home, usually their PSW through a company, Mosaic, would go with them. So an emergency room is extremely overwhelming in the emergency department itself. So that's great that there are like programs and things like that put in place to kind of help.
We often call that a geriatric cart.
Mm,
Quite a number of hospitals. Thanks, Dr. Stewart, for referencing Mayo Clinic. My friend Fernanda Bololio, one of the docs there, started a geriatric cart program there. So, and we have one at Sinai, and many places do. So, used by our geriatric volunteers and others, but it's kind of it's like a resuscitation cart specifically for older person needs. So, it has all of those things. An iPad on it, for example, a hearing assist thing, activities to keep the person distracted, iPhone chargers, eye blinds, those sorts of things. So yeah, and if you, I haven't yet talked about the Geriatric ED Collaborative.
you can go ahead and speak about that actually.
Nice cue for that. So, if you wanted to learn more about how to implement a geriatric volunteer program or a geriatric ED cart, I am involved with a group called the Geriatric Emergency Department Collaborative, generously supported also by John A. Hartford and the West Health Foundation, which is an organization that aims to improve care of older people in emergency departments around the world. It has, I suspect the link is going to be posted. It has a huge amount of resources on it, including links to our bi-monthly webinars, which I organize. But also, like, if you want, there's a fantastic toolkit around implementing an elder mistreatment process in your emergency department, which includes the screening tools, guides to staff training, what to add to your IT systems. So if an emergency department was interested in how to implement elder mistreatment process, it's all there. There's really there's educational programs for nurses and doctors. I could go on and on, but it's a fun website just to poke around in and to see what's going on.
Absolutely. Let's see over here, and then just another comment here from Jane T. Still. Just I think we were prior to this conversation in the morning, we were talking about this. Dr. Melady, he asked, "I do work closely with Dr. Samir Sinha through Mount Sinai. He works extremely hard on age-friendly communities and the aging strategy." If you wanted to briefly just touch on that.
Well, so I too have been working very closely with Samir, who's been one of our biggest supporters of improving care across the spectrum, both in hospital, but also in the community and in that place that bridges the two places, which is often an emergency department. The geriatric emergency department, we sometimes think of the emergency department as the front door to the hospital. A famous quote line about the geriatric emergency department created by Yula Huang is that the geriatric emergency department is the front porch of the hospital. So it's really not, the goal is not to just admit everybody to the hospital, but to get them back home and avoid unnecessary admissions. And to do that, the emergency department needs to have a strong link with the community. And that's like, I'm not going to sugarcoat this. Emergency departments are often not good about making that connection. And are often sort of feel like little islands of care. So part of the geriatric emergency department is, and it's often the gem nurse or the social worker or that interdisciplinary care that does this. Part of the emergency department is making sure that you're connected to your community, that you know what resources are out there, how you can best serve the person. Like an example would be a person with presenting to emergency department with the behavioral and psychological symptoms of dementia, agitation or other that is difficult to provide care for at home. The reflex answer to that would be to admit the person to hospital, to internal medicine, which I think everybody knows is like not really a great solution. Now in Toronto, at least, and in many places, there are behavioral support outreach teams that are available to see that person in their home on a very timely basis. Our team commits to within 48 hours. So if you know that, and if you have a link to that organization and like a person you can call and say, I've got this person in our emergency department who really needs your services, then that you can avoid the admission that is not going to be helpful and get the person back home and get them the care in the place, get them the care they need in the place where they need to be. So I'm quite sure, I can't remember what the question was exactly, but the answer is emergency departments, if they're going to function well for older people, need to be connected to their communities.
Absolutely. Just that, I think what we talked about today, there needs to be connection between communities, people. There's intersectionality of care that needs to be considered, a whole bunch of factors that go into, just the emergency department alone. So that's fantastic. Now that we are slowly coming close to the end of today's Global Cafe, before we wrap up, I would love to hear your key takeaways from today's discussion, Dr. Melady. So I'll give you a little time to just gather some of your thoughts as I'll introduce our next week's topic and speaker right now. So please join our discussion next week with Dr. Andrea Wershoff-Schwartz on the topic of age-friendly medical education. So please join us to listen to that great discussion next week. So now we're back to you, Dr. Melady. In a few sentences, what are some of your key takeaways from our conversation today that you would like for all of us to kind of leave with?
Well, thanks for that cue from next week's talk, and I might I do. The focus, my academic focus, has been education. I have a master's in medical education, and it goes back. I mean, a clear takeaway is this three-part people, processes, and place approach to older person care in any setting, including in the emergency department. And so, thinking about your people and what they need to know, and whether it's a bus driver or a travel agency or like whoever it is that's dealing with older people on a regular basis, what do they need to know in addition to their core knowledge set to provide better care to older people? So so always thinking about people and the processes, and being aware that having a person who wants to do the right thing working in a system that prevents them from doing the right thing is not a success. So you need to have the person who wants to do the right thing working in a system that allows and encourages and even requires them to do the right thing. So that would be one big takeaway. And I just I think it's good for people to know that like the field of geriatric emergency medicine exists. It is joined by many other specialties. So there's like geriatric oncology, cancer care, geriatric surgery has been a real trailblazer in changing their processes around providing care for older people. Geriatric ophthalmology, one of our ophthalmologists is similarly involved, geriatric psychiatry for sure. So, people are thinking about older people, and the good news is we're winning. People are paying attention, systems are changing, the aforementioned accreditation process shows that. There are resources available. Please visit our website, Geriatric ED Collaborative. I think those would be my main points.
Amazing. Thank you so much. Before we sign off, I would also like to thank everyone again for another great week of Global Cafe sessions, with special thanks to Dr. Don Melady for joining us today, and providing all of these great, fantastic insights. And also to the incredible people working here at the IFA who have supported this and every Global Cafe, in particular, Miss Luana Colnago as well. So thank you, everyone. I know we're at the 8 o'clock hour, at least here in Toronto. So we hope to see you all next Friday, and wish everyone a great weekend. Thank you so much. Take care.
Nice being here. Nice seeing
Thank
you.
you so much.